We're grateful to be back with you. This is the 5th panel for the Machine Learning from Ground Truth workshop at the NeurIPS conference. And I'm really thrilled to be in conversation for this session with someone who I've had the opportunity to work with a lot over the past year and a half and commiserate a lot with over data access problems, and also hear about computational medicine through the lens of a funder. So Daniel Yang is the program director for diagnostic excellence with the Gordon and Betty Moore Foundation. We're very privileged to have the Moore Foundation as an anchor funder for Nightingale Open Science. And Daniel, you have a really unique perspective on this space as both a funder and someone who's been looking at these problems and talking to so many different people in the field for a long time, as well as a practicing physician. So in the clinic, routinely seeing patients and seeing potentially what this work can impact in the clinic positively, and then all the things that need to be done to kind of get us where we need to be. So I think we'll have a great conversation today just about kind of the problems and opportunities from the perspective as a funder and the clinical perspective, and kind of where Nightingale is hopefully helping to fill those gaps and what we can do more of. And then we'll also make an exciting announcement at the end about something we're doing to scale the field. So Daniel, I was wondering if you could open just by telling us a bit about the Moore Foundation's focus on diagnostic excellence and what you all focus on.
Great, thank you, Katie. Yeah, happy to talk a little bit about the Moore Foundation and our diagnostic excellence portfolio. So for those unfamiliar, the Moore Foundation is a private philanthropic organization located in Palo Alto, endowed generously by Gordon Moore, the co-founder of Intel. And one of our program areas is patient care or healthcare. And within that, our primary or major initiative is focused around diagnostic excellence. So in particular, how do we improve the diagnostic process? How do we minimize delays and inaccurate diagnoses, which are unfortunately the most common, as well as consequential medical errors that patients experience? So within that, we're focused on 3 clinical categories of disease that we know account for a disproportionate share of harm from suboptimal diagnosis. A lot of this is focused on diagnoses that are made in acute settings, so time matters a lot. So things like heart attacks, strokes, infections like sepsis and pneumonia. And then on the outpatient side, cancer. So missed and delayed cancers obviously are a huge cause of poor outcomes. So within our broader initiative, we have a technology portfolio. And in that, we're looking at the use of data-driven approaches and new technologies to support the diagnostic process, to augment clinicians. And just as a quick aside, our office, which is located in Palo Alto, is literally located across the street from the defunct offices of Theranos. So when we were going into the office, every time I drove in, I was just reminded by both the hype that exists around this field of diagnosis, but for me, it also reflects just the incredible public demand and enthusiasm around this notion that we can do diagnosis better. So I think it's just important to see both sides of that. And so we take the positive aspect that that we know we can do better in diagnosis, and so our foundation is committed to that.
That's great, and I think speaking to the demand that makes people crave something that might not be all it's cracked up to be, like in the case of Theranos. You and I have spent a lot of time over the past 2 years just talking about the woeful state really of data access in this space. And not only that, not only the fact that the data is not available, but that sometimes, frequently, the data that is available is kind of disconnected from the needs that physicians actually have or what they're seeing going on with their patients. So I was wondering if you could just tell us a little bit about what gets you excited about funding Nightingale and the data that we have on the platform, and from your perspective as a physician as well.
Yeah, I like that point about disconnection between kind of the clinical AI that I see being generated or the publications that I see versus just the clinical reality of maybe what patients and providers would benefit from. And so, one thing that I see a lot of putting my provider hat on is I see, for example, all of these sepsis prediction algorithms that are trying to predict sepsis 30 minutes earlier or an hour earlier in patients who are in the ICU. And, on one hand, yes, that's important, valuable work. But on the other hand, I'm like, that's not the environment that I'm worried about. So I actually work in the emergency department setting, and I'm thinking to myself, like, these patients are in the ICU. Like, you're gonna figure out if they have sepsis sooner or later. You have, 1 hour, you have like continuous physiologic monitoring, you have a one-to-one nurse, you have an ICU team that's closely attuned to changes in these patients. So for me, like, that's not where the interesting prediction problem is. And yet I can't tell you how many times I see like another group that wants to develop a slightly better prediction algorithm in that setting. And so, I think a general trend that I see is that researchers are developing algorithms not based on what's clinically useful, but based on what they have access to data to study. And I loved the analogy that was shared earlier about researchers having to kiss 100 frogs in order to find their prince. And I get that it's really hard for researchers to find access to new data sets. And so instead, they rely on the same publicly accessible data sets. And you can only answer a limited set of novel questions that haven't already been explored. So anyway, I see this massive disconnect between clinicians that I think would really benefit from AI assistance. So for example, in the ER, and using the sepsis example, the patients that I worry about are not the patients that I admit to the hospital. It's the patients that I send home. So for example, if someone came to the emergency department and they don't have the classic signs and symptoms of sepsis, they don't have a really high fever or a very high, white blood cell count or a high lactate, they maybe have some mild abnormalities. Maybe they're older, maybe they're a little bit confused off baseline. They don't meet the traditional criteria for sepsis. And some of these patients will do just fine if I sent them home with a round of antibiotics or just close monitoring, and other people will do very poorly. And that's the type of help I want from an algorithm, is which patients are not going to do well that maybe I should admit because it's early sepsis, and which patients are going to do just fine. And it's the same exact question that we heard about COVID around trying to predict clinical deterioration. So anyway, those are the algorithms I'm not seeing. And the reason I'm not seeing them, I know, is because we don't have data on these patients. And so, I'm reminded of the cartoon, the analogy of just looking for the keys under the lamppost. We're asking the clinical questions that we have data to solve. And yes, we don't know what happens to patients after discharge because they're at home. We don't have continuous monitoring of those patients the same way we do for ICU. So anyway, what I love about the Nightingale platform and just the entire premise of this workshop is it takes that paradigm of we study what we have access to data to study, and it flips it on its head, which I think is the logical approach, which is first you ask yourself, what are the clinical questions that we need to solve that maybe AI can help with? And then what are the data assets that will give us insight into those problems? And then where do we find those data assets? Where do they live? And then how do we get those data assets in a format that's available for researchers more broadly? So I think that approach, to me, is a logical one. And so I love that Nightingale is approaching them that way. It's one of the reasons we're enthusiastic about this program.
That's great. Yeah, thank you so much. I think that, doing the hard work of partnering with physicians and others who work in a clinical space to understand the real needs and the clinical problems is something I think that's hopefully going to transform the field and kind of steer researchers in the right direction in terms of what to be focusing on and what to look at. And from a funder perspective, I'm curious, what you're hearing and seeing. You fund a lot of researchers directly, research projects, and I'm sure that everyone in the audience can relate to a lot of the issues that your grantees are seeing. And I'm wondering if you can just kind of surface some of those and talk through like the main pain points your grantees see today, going beyond potentially data access, but just like navigating this entire system to be able to actually output a paper.
Sure. Yeah. I mean, we hear a lot from researchers or grantees around data access. So we've been hearing it today, and that it tracks with the conversations we've been having. And I think, to put on the funder hat, the irony of this is funders like us, but also, public funders like the NIH, we deploy a lot of grant funds to do projects that require the development of new clinical data assets, right? So most of our grant money, oftentimes for these projects, actually goes into like data wrangling and collecting and aggregating and cleaning this data, which is then used to do the analysis. But after the analysis done and the paper is published, this data asset just sits idle somewhere. And so as a funder, like we think about the social ROI for our investments. And the fact that we, the majority of our investment goes into this data asset, but if the data asset is only used once, or a few times, is just a poor investment. And I think that when you think from the researcher standpoint, I understand why this is the case. One, Ziad mentioned earlier around, the poor enforcement of these data sharing clauses. I mean, we have a data sharing clause as well. I think that funders can do a better job of, I wouldn't say just incentivizing and mandate data sharing, but it's also an unfunded mandate most of the time. So we realize that it requires time, it requires resources, it requires technical and social expertise that may not exist in the team. It's a different set of competencies, to figure that out oftentimes than it is to just do the analysis and publish the paper. And so one, I think there is a responsibility in the funder community to recognize the need for resources, both financial and others, to ensure that the data assets created from the project we fund have a life outside of the specific use case for one particular project. I think it requires, for example, for us, we were an early proponent of the open science, open access publication movement. I think there needs to be a similar one when it comes to data sharing. But from the researcher perspective, we also see that the few researchers that are just so professionally incentivized to like make these data assets available, even if it's like nights and weekends and it's not funded work, it oftentimes requires the creation of like one-off infrastructure for one data set, so that they need to go into their institutions and negotiate the data sharing agreement. They need to figure out the de-identification process. They need to figure out, who has access to this, in what setting, et cetera. And again, it's just a very inefficient process. So I think for me, it just makes a very strong case of why we need reusable infrastructure. Why a platform like Nightingale that has expertise in just the act of being able to extract, to host these clinical data assets is just required, because I don't think we should rely on researchers to do it necessarily on their own. And yet the alternative, I think, is also suboptimal, which is just letting all of these really valuable clinical data assets be unused.
Yeah, we've had so many, conversations, user research conversations with researchers over the course of building Nightingale, and heard exactly what you're saying over and over again, that, everyone wants to share this data, but the hurdles in place are just so time consuming that most people understandably just can't prioritize it. And we were lucky enough to have time and resourcing, thanks to you and to Schmidt Futures, early on at Nightingale, to be able to invest time in setting up a legal framework and DUAs and really negotiating with all of our partners so that we could land in a place where they felt comfortable making the data available, which is really important to us, and also that the data was in a useful format for researchers. Because I think the other thing we see is that, like, a lot of times if you can successfully negotiate to the point where you get the data, it's been so kind of stripped down that it's hard to do anything useful with it. So we really wanted to walk that line very carefully.
And I would just add that, I think the context we're talking about are oftentimes very successful research groups at kind of leading institutions. So it by itself is a very privileged class. And even they are finding it really difficult to kind of navigate this landscape to be able to share their data more publicly. And so then you kind of think about, well, what about all the other healthcare systems out there that may not have either the infrastructure, the data infrastructure, the legal infrastructure? They may not have the research incentive to kind of make this healthcare data usable. It's just so much harder for them to participate. And so what we're seeing, again, unsurprisingly, but with huge social implications, is the fact that the majority of these publicly available data assets just come from 3 states. They come from Massachusetts, from New York, from California, and predominantly from leading academic medical institutions within those states. And these are the data sets that are being used to generate clinical algorithms. Presumably, they may be used in different contexts, different clinical contexts in which the demographic profile looks very different, or in rural communities as opposed to urban communities. And so, I think that there is a responsibility to really think about how do we lower the barriers for these other healthcare systems to participate and to donate in some ways their data to these public repositories, such that these repositories are more reflective of a general population, and therefore hopefully so are the tools that are generated from them. So we gave a grant, and I'm sure to you to work with Contra Costa County health systems. And I think we knew it would be difficult, but I don't think we knew it would be that difficult. So maybe you can share a little bit about your own reflections on, working with a non-traditional player in this space.
Yeah, it's a great example to draw on and a great snapshot of how hard it is to do this work with institutions that have not historically had the resources to do it, as you say. And I think it's, it's easy to say, oh yeah, we'll partner with this institution, we'll apply all our regular frameworks that we've ironed out, we'll go in and do our regular data curation process, and it'll be a lot of time and work, but we'll come out with the data set. It looks very different to do that in practice with an institution that, and I want to highlight Contra Costa Health Services is one of our anchor partners. They've been amazing partners to us. The CEO, Anna Roth, and the chief technology officer, Rajiv Pramanak, I think he's on today. They've been amazing to work with. And they actually came to us saying, we have all of these deep data assets that are actually linked at the county level. So within the health system, we actually have access to court data and educational outcome data and all these other data that are representative of social determinants of health of the population of the county. This is also a public health system that serves a really diverse community. So, a lot of underrepresented populations are captured and served in that health system. And so they basically came to us and were interested in partnering on projects to actually make use of their deep data assets. And what they didn't have was just the historical investment of like, maybe a Harvard or a Stanford of how to do research, how to put together big data environments internally so that you can store data sets, how to staff up an internal data team to be able to extract imaging data or any sort of clinical data that you want from all these disparate systems. And so just to give you a really, really kind of crisp snapshot of the work we're doing with them, we have a few different projects with Contra Costa. The one we're working on right now, and the V1 data set is out on the Nightingale platform today, is a massive data set of ECG waveforms linked to all sorts of ground truth outcomes from the EHR. And it's taken us 2 years to build this data set because in order to extract the images from the health system, we actually had to work with a third-party vendor system that supplies the hospital with, infrastructure for their imaging data. And then we worked really closely with their amazing analytics team, Contra Costa's amazing analytics team, to pull and store the EHR data, but there had been no historical data environment or infrastructure to store that in for a project like this. So we worked with them to set that up. And then, this is the technical work. We negotiated through the county our data use agreement, our IRB, and all of that adds up to quite a lot of investment and a lot of time and money that is 100% worth it to be able to accurately reflect the true population instead of just, it's certainly easier to do this at a place that kind of churns out research year after year. And so what we're doing is really making an investment in this health system to support them and hope that they'll continue to be able to execute on research like this and on insights from our platform for years to come.
Yeah,
so,
I would just add to that, as being on the funder side throughout that entire process, just echoing what you said, how much work it takes to do it well. The element of trust building that's embedded in this, the element of really training and learning alongside each other. So it's not just simply turning on a switch. And I would say a credit to your team is that you came out of this experience. Most people would be like, we're done. We've done it once. And, we realize why it's so hard, but, credit to your team to say, we've done it. We've learned a lot from this process. It can be done. And we want to do it again and again and again because there's a public benefit for it. So again, just kudos to your team because, it's not easy work. Like you said, you talked deep assets, like it's deep work to figure this stuff out. And so I just applaud your team for sticking with it and for working with a system that was incentivized, that wanted to do it and just making it work.
Yeah, absolutely. I think we've seen that the only way to really make this a reality is to invest the massive amounts of time and and energy and also money that comes with it, And I should have mentioned that we employ generally at Nightingale a give to get model. So we are completely philanthropically funded. And how we work with health systems to work with them on data sets and then eventually put the data sets on our platform is we deploy a seed grant to that system that's very strategically structured around what they need to build the data set. And that can go to anything. It could go to staffing up on the data science side so that they have analysts who can pull and analyze the data. It could be infrastructure upgrades, just general time for general funding for leadership time and attention to the project. But we deploy that to the health system and then we work with them very collaboratively, as we just talked about, to kind of build up the data sets. And I think that, there is a recognition that for some of these institutions that historically have not had a lot of resources to do this work, we want to correct that. And we want to be able to bring funder attention to that, say this is so important. And we are prepared to do this work. And we actually have worked with these health systems and know exactly what they need to get it done. And I'm so glad that we have a partner in you and the Moore Foundation to do that work. And this actually brings me to something that I'm really excited to announce, which is a new funder collaborative that's kicking off in the spring of next year. This will bring together 3 foundations and counting: the Moore Foundation, Schmidt Futures, and the Patrick J. McGovern Foundation. And really what this is a new collaborative, a new group to put money and resources towards scaling the field of computational medicine. So we at Nightingale, we now know we have a blueprint for how to do this, depending on the resourcing that an institution has to do this work. We support them in various ways, and that takes various amounts of support. We're going to be putting out a specific call, a request for proposal to health systems from all over the world. So not just in the US, but all over the world, and not even limited to health systems. Other institutions who have clinical data can apply as well, to work with us to create data sets around data sets that are on, like the data sets that are on the Nightingale platform that we've been talking about today, deep medical mysteries that we still don't know enough about. That call is going to go out and invite any health system, any institution with data to apply, to work with us, and then have their data featured prominently on the platform for researchers to use and create amazing models with, and hopefully generate groundbreaking research. So, Daniel, I want to hear kind of your thoughts about this collaborative, because we've worked very hand in hand to kind of craft this. But I do want to say that we're now accepting new funders to join the collaborative of our anchor funders until April 1st of 2022. So if you're interested, go on our website or on our Twitter account. Our handle is Nightingale OS, and send us a message, and we are excited to talk with you.
And I would just echo Katie, and any funders on the call, I'd invite you to reach out to me as well. Happy to give you our perspective. I shared some points earlier today of what made us so excited about this. But happy to provide additional perspective on why we think this is such a worthwhile investment, whether it's Nightingale or other platforms. I mean, I mentioned earlier, in order for us to really truly realize the full impact of our investments, we need data sharing platforms like this. It makes me excited that in the future, it perhaps will be our expectation for grantees supported by the Moore Foundation, that they will deposit their data assets in a platform like Nightingale or something else, after their primary analysis is done, to ensure that the data sets have a life after the primary analysis. So, we think that these types of data infrastructure investments are critically important. I would say, if there's one lesson that I've learned from the pandemic, it's really the lack and the absence of clinical data assets just like this. I don't have time to share an anecdote about trying to identify or dig up these data infrastructure, but really there was none. These things had to be stood up de novo in the middle of a pandemic. Data sharing agreements had to be sorted out in the middle of the pandemic. And it's remarkable, just that alone, data sharing agreements, how much that particular element slowed down the ability to aggregate data and to make that data available to researchers. So, I think this type of work is critically important. I'm really excited about the team, the mission and the vision of the Nightingale OS platform. And I hope that it's, that the government is listening, because I think that this hopefully becomes a blueprint for something that is truly national in scale. I think 10 data sets is a huge, an important step forward, but we need to be talking about thousands, of data sets. And so, Elements of the work that Katie described are scalable, but elements of it is really bespoke. It really is negotiating on a individual system by system basis. So anyway, I welcome additional funders into our collaborative. I welcome people to reach out to me. This is a topic of great interest for us at the foundation, and we're trying to build a community of funders that really agree with us on these principles.
Absolutely. Yeah, so more coming in early next year. And just thank you so much, Daniel, for your time and insights today. This has been a great conversation, and I feel like we're just getting started.